Today, we are going to discuss the physiologically difficult airway, a pivotal topic for managing critically ill patients. While anatomical challenges like a high Mallampati score or cervical immobility are well known, physiologic derangements, specifically hypoxemia, hypotension, severe metabolic acidosis, right ventricular failure, pericardial effusion, tamponade, obesity, pregnancy, and high aspiration risk, pose equally significant risks during intubation. These conditions can lead to catastrophic outcomes, such as cardiovascular collapse, if not meticulously addressed. We will dissect the pathophysiology of each derangement, discuss evidence-based management strategies, and analyze clinical cases to enhance your clinical acumen. Let us proceed with a focus on integrating this knowledge into your practice. Hypoxemia, defined by a reduced PaO2, is a frequent precipitant for emergent intubation in the ICU. Its etiologies include shunt, for example, pneumonia or ARDS, VQ mismatch, diffusion impairment, and hypoventilation. Physiologically, hypoxemia compromises oxygen delivery, triggering compensatory responses like tachycardia and tachypnea to maintain tissue oxygenation. However, critically ill patients often have diminished functional residual capacity, FRC, due to atelectasis or obesity, and elevated oxygen consumption from sepsis or fever, resulting in perilously short safe apnea times, sometimes less than 30 seconds. This necessitates robust pre-oxygenation strategies to extend this critical window and prevent hypoxia-induced complications. The ICU approach emphasizes tailored pre-oxygenation based on the underlying cause of hypoxemia, which we will explore next. Effective management of hypoxemia during airway intervention hinges on optimized pre-oxygenation and apneic oxygenation. The non-rebreather mask, while standard, often achieves only 60 to 70% FiO2 due to air entrainment. Non-invasive positive pressure ventilation, such as BiPAP, applies PEEP to recruit collapsed alveoli, significantly improving oxygenation in shunt physiology, for example, ARDS. High-flow nasal cannula, delivering up to 60 liters per minute of heated, humidified oxygen, provides near 100% FiO2 and generates 3 to 5 centimeters of water of PEEP, making it invaluable for patients with high inspiratory demands. Apneic oxygenation via nasal cannula at 15 liters per minute or via heated high-flow device sustains alveolar oxygen diffusion during laryngoscopy, potentially extending safe apnea time by several minutes. The ICU approach introduces delayed sequence intubation, DSI, where a dissociative dose of ketamine, 1 mg per kilogram, is administered to facilitate pre-oxygenation in agitated or non-cooperative patients, allowing for effective denitrogenation before paralysis. Additionally, using a PEEP valve with bag valve mask can maintain alveolar recruitment during manual ventilation, further optimizing oxygenation. These strategies collectively aim to maximize intrapulmonary oxygen stores, ensuring a controlled and safe intubation process. Here's a case example. Consider a 55-year-old male with severe community-acquired pneumonia, presenting with SpO2 of 85% on room air, respiratory rate of 32 breaths per minute, and accessory muscle use. Chest X-ray reveals bilateral infiltrates, indicative of shunt physiology. His reduced FRC and high oxygen demand place him at risk for rapid desaturation during intubation. We initiated pre-oxygenation with high-flow nasal cannula at 60 liters per minute and 100% FiO2 for 5 minutes, but his agitation hindered effective oxygenation. Employing delayed sequence intubation, we administered ketamine 1 mg per kilogram, achieving a dissociated state that allowed for uninterrupted pre-oxygenation, raising his SpO2 to 95%. During intubation, apneic oxygenation via nasal cannula at 15 liters per minute maintained his SpO2 above 90%. This case illustrates the efficacy of combining high-flow nasal cannula, delayed sequence intubation, and apneic oxygenation to manage hypoxemia, transforming a potentially chaotic scenario into a controlled intervention. Now let's discuss intubations complicated by hypotension. Hypotension, defined as systolic blood pressure less than 90 millimeters of mercury, or mean arterial pressure less than 65 millimeters of mercury, is a common comorbidity in critically ill patients requiring airway management. Its origins include hypovolemia, vasodilation, or cardiac dysfunction. Physiologically, hypotension reduces organ perfusion pressure, prompting neurohormonal responses like catecholamine-mediated vasoconstriction and tachycardia. However, positive pressure ventilation during intubation elevates intrathoracic pressure, increasing right atrial pressure and diminishing venous return, a critical preload determinant. In preload-dependent states like hypovolemic or distributive shock, this can precipitate a profound drop in cardiac output, with mean arterial pressure declines of 20 to 30 millimeters of mercury or more within minutes. Peri-intubation hypotension is strongly correlated with adverse outcomes, including a threefold increase in mortality risk. Thus, preemptive stabilization is essential to avert these consequences. Effective management of hypotension during airway intervention requires a systematic approach to hemodynamic optimization. Fluid resuscitation is the first step for volume-responsive patients, guided by dynamic indices such as inferior vena, cava collapsibility, greater than 50% suggests responsiveness, or a passive leg raise, which predicts a greater than 15% increase in cardiac output with fluid administration. Crystalloids, for example 20 to 30 milliliters per kilogram, or blood products are appropriate based on the clinical context. Hemorrhage mandates the latter. For persistent hypotension, norepinephrine provides alpha-adrenergic support to maintain systemic vascular resistance and mean arterial pressure. Transient hypotension during induction can be countered with phenylephrine boluses, 50 to 200 micrograms, leveraging its rapid onset vasoconstriction. Induction agent selection is critical. Etomidate and ketamine are preferred for their minimal impact on hemodynamics, unlike propofol, which can reduce mean arterial pressure by 20 to 40% due to vasodilation and myocardial depression. In the ICU, you can consider a pre-intubation vasopressor bolus with phenylephrine for patients with a shock index greater than 0.8, which is calculated by taking heart rate divided by systolic blood pressure, further reducing the risk of peri-intubation hypotension. The goal is to achieve a mean arterial pressure greater than or equal to 65 millimeters of mercury pre-intubation, minimizing the risk of cardiovascular collapse. Now, let's put this into action. Here is an example case. Consider a 62-year-old female with septic shock from urosepsis, presenting with a blood pressure of 80 over 50 millimeters of mercury, heart rate 120 beats per minute, and lactate 5 millimoles per liter, markers of severe hypoperfusion. Her vasodilatory state and probable hypovolemia heighten her risk for peri-intubation hypotension. We administered a 1-liter crystalloid bolus, guided by IVC ultrasound showing greater than 50% collapsibility, confirming volume responsiveness. Her BP improved to 90 over 55. Persistent instability prompted norepinephrine at 0.05 micrograms per kilogram per minute, targeting mean arterial pressure greater than or equal to 65 millimeters of mercury. Additionally, recognizing her shock index of 1.33, which is heart rate divided by systolic blood pressure, we administered a pre-intubation phenylephrine bolus of 100 micrograms to counteract the anticipated drop during induction. For induction, we chose ketamine, capitalizing on its sympathomimetic effects. Throughout intubation, her BP stabilized at 95 over 60, with no evidence of collapse or organ hypoperfusion post-procedure. This case exemplifies the necessity of preemptive hemodynamic support, integrating fluid resuscitation, vasopressors, and judicious agent selection to ensure a safe airway intervention in a critically hypotensive patient. Moving on to severe metabolic acidosis. Severe metabolic acidosis with a pH below 7.2 arises from excessive acid accumulation, for example, ketones in DKA, lactate in sepsis, or bicarbonate loss, for example, renal tubular acidosis or profuse diarrhea. This acidemia disrupts cellular homeostasis, impairing glycolysis, reducing myocardial contractility, and increasing arrhythmia risk via potassium shifts. The body compensates through Kussmaul breathing, a deep and rapid hyperventilation pattern that can exceed 40 liters per minute in minute ventilation, lowering PaCO2 to as little as 10 to 15 millimeters of mercury to buffer pH toward normalcy. During intubation, apnea halts this compensation, causing PaCO2 to rise by 3 to 8 millimeters of mercury per minute initially, then 1 to 2 millimeters of mercury per minute thereafter, driving pH down precipitously. For example, a pH of 7.1 could drop to 6.9 within 60 seconds. Post-intubation, mechanical ventilators often fail to replicate this extreme ventilatory demand, risking relative hypoventilation and worsening acidemia. This physiologic complexity demands a strategic approach to preserve or mimic the patient's compensatory mechanisms during airway management. In severe metabolic acidosis, the optimal management strategy is to defer intubation when feasible, employing non-invasive positive pressure ventilation, for example, BiPAP with IPAP of 12 to 15 centimeters of water and EPAP of 4 to 6 centimeters of water, to offload respiratory effort while addressing the underlying etiology. This preserves the patient's compensatory hyperventilation, avoiding the abrupt loss of PaCO2 regulation. If intubation is unavoidable due to respiratory fatigue or airway protection, spontaneous respiration should be maintained by minimizing neuromuscular blockade. If paralysis is essential, succinylcholine is preferred for its rapid offset of 5 to 10 minutes. Post-intubation, ventilatory support must align with the patient's intrinsic drive. Pressure support ventilation or pressure control allows patient-triggered breaths, targeting tidal volumes of 6 to 8 milliliters per kilogram of ideal body weight and rates of 30 to 40 breaths per minute to match pre-intubation minute ventilation. The ICU approach also suggests considering bicarbonate infusion for pH less than 7.1 if ventilatory support is insufficient, though this remains controversial due to potential paradoxical intracellular acidosis. In refractory cases, extracorporeal CO2 removal can be employed to manage hypercapnia and acidemia, though it is resource-intensive and not widely available. Vigilance for auto-PEEP, due to incomplete exhalation at high respiratory rates and respiratory muscle fatigue, is critical, as these can exacerbate acidosis or delay recovery. Here is an example case. Consider a 34-year-old male with DKA, presenting with an arterial blood gas showing pH 6.9, PaCO2 of 15 millimeters of mercury, and HCO3 of 4 millimoles per liter, alongside a respiratory rate of 40 breaths per minute and minute ventilation of approximately 45 liters per minute, a testament to maximal respiratory compensation. The challenge is to sustain this ventilatory effort during airway management. Initially, we applied non-invasive positive pressure ventilation with BiPAP, reducing his work of breathing while insulin and fluids corrected ketosis. His pH rose to 7.0 over 2 hours. However, progressive fatigue, evidenced by accessory muscle exhaustion, necessitated intubation. We employed pressure support ventilation, enabling him to maintain a respiratory rate of 35 to 40 breaths per minute and tidal volumes of 800 to 1,000 milliliters, closely approximating his spontaneous effort. Post-intubation, his PaCO2 stabilized at 18 millimeters of mercury, and pH remained steady, avoiding the feared acidotic spiral. Bicarbonate infusion was considered, but deferred as his pH improved with ventilatory support and metabolic correction. This case underscores the importance of supporting, rather than supplanting, the patient's compensatory physiology in severe metabolic acidosis. Now let's talk about right ventricular failure. Right ventricular failure arises when the RV fails to sustain cardiac output against elevated afterload or due to intrinsic contractile dysfunction, as seen in acute pulmonary embolism, chronic pulmonary hypertension, or RV infarction. The RV, a thin-walled, crescent-shaped chamber, operates under low pressure. Normal pulmonary artery systolic pressure approximates 25 millimeters of mercury and is exquisitely sensitive to afterload increases. Elevated pulmonary vascular resistance, for example from hypoxic vasoconstriction or thromboembolism, causes RV dilation, shifting the interventricular septum leftward, reducing left ventricular filling, and compromising systemic cardiac output. Positive pressure ventilation exacerbates this by raising intrathoracic pressure, compressing pulmonary capillaries, and increasing RV afterload by 10 to 20%. In severe cases, this can precipitate acute RV decompensation, dropping mean arterial pressure below 60 millimeters of mercury and risking circulatory collapse within minutes. Distinguishing RV dysfunction, compensated, from failure, decompensated, via echocardiography is vital as it dictates the urgency and nature of intervention during airway management. Managing RV failure during airway intervention demands a tailored approach to oxygenation, hemodynamics, and ventilation. Pre-oxygenation with high-flow nasal cannula at 40 to 60 liters per minute with an FiO2 of 100%, or non-invasive positive pressure ventilation optimizes oxygen saturation while limiting intrathoracic pressure increases compared to mechanical ventilation. Hemodynamic support hinges on RV status. Fluids are beneficial only if contractile reserve exists. Overzealous administration risks worsening dilation. Norepinephrine is the vasopressor of choice to maintain mean arterial pressure greater than or equal to 65 millimeters of mercury, countering systemic hypotension. In cases of RV systolic failure, dobutamine enhances contractility without significantly increasing afterload. Inhaled pulmonary vasodilators, such as nitric oxide, may help to selectively reduce pulmonary vascular resistance and RV afterload, particularly in patients with pulmonary hypertension or acute RV strain. Post-intubation, ventilatory settings should minimize RV strain. Tidal volumes of 6 to 8 milliliters per kilogram of ideal body weight, PEEP of 5 to 8 centimeters of water, and avoidance of hypoxemia or hypercapnia. Additionally, plateau pressures should be kept below 30 centimeters of water to prevent further increases in RV afterload. This balanced strategy preserves RV function and systemic perfusion. Here is another example case. This is a 50-year-old female with a massive pulmonary embolism, presenting with RV dilation and a TAPC of 12 millimeters on echocardiography, indicating systolic dysfunction, and a blood pressure of 90/60, signaling impending decompensation. The challenge is to secure her airway without triggering RV collapse from positive pressure ventilation. We pre-oxygenated with high-flow nasal cannula at 50 liters per minute and 100% FiO2, achieving an SpO2 of 94% with minimal intrathoracic pressure increase. Her borderline hypotension prompted us to start norepinephrine, raising mean arterial pressure to 70 millimeters of mercury pre-intubation. Additionally, we initiated inhaled nitric oxide at 20 parts per million to selectively dilate pulmonary vasculature, reducing RV afterload. During intubation, we employed a lung protective strategy, a tidal volume of 6 milliliters per kilogram, PEEP of 5 centimeters of water, and a plateau pressure of 25 centimeters of water, to limit mean airway pressure and preserve RV function. Post-intubation, her blood pressure stabilized at 100/65, and RV function, monitored via pulse pressure variation, showed no further deterioration. This case illustrates the critical interplay of oxygenation, hemodynamic support, pulmonary vasodilation, and ventilatory restraint in managing RV failure, ensuring a safe transition to mechanical ventilation without compromising circulatory stability. Now let's talk about the impact of obesity. Obesity, characterized by a BMI greater than or equal to 30 kilograms per meter squared, presents unique challenges in airway management due to its impact on respiratory mechanics. The accumulation of adipose tissue in the chest wall and abdomen compresses the lungs, reducing functional residual capacity, the volume of air remaining after a normal exhalation, which serves as the primary oxygen reservoir during apnea. This reduction, often by 20 to 50% in obese patients, coupled with increased oxygen consumption from elevated metabolic demand, accelerates desaturation during intubation. For instance, a patient with a BMI of 40 may desaturate to less than 90% within 1 to 2 minutes of apnea, compared to 5 to 8 minutes in a non-obese patient. Additionally, obesity is frequently associated with obstructive sleep apnea, which exacerbates upper airway collapsibility, further complicating ventilation and intubation. Understanding these physiologic alterations is critical for anticipating and mitigating peri-intubation risks in this population. Managing the obese airway requires a multifaceted approach to counteract the physiologic challenges of reduced functional residual capacity and rapid desaturation. The ramped position, achieved by stacking blankets to elevate the head and shoulders until the external auditory meatus aligns with the sternal notch, optimizes the glottic view, and extends safe apnea time by improving lung expansion. Pre-oxygenation is critical. High-flow nasal cannula at 60 liters per minute with 100% FiO2, or non-invasive positive pressure ventilation helps recruit alveoli and denitrogenates the lungs, achieving an SpO2 greater than 95% before intubation. Videolaryngoscopy is preferred over direct laryngoscopy due to improved visualization in the presence of excess soft tissue, reducing the number of attempts and time to intubation. The goal is to maximize oxygen reserves and ensure a clear airway path, minimizing the risk of hypoxia and failed intubation, which can occur in up to 15% of obese patients without these measures. Let's put this knowledge into action. Here is another case example. Consider a 48-year-old male with a BMI of 42, a history of OSA, and acute pneumonia, presenting with an SpO2 of 88% on room air and a respiratory rate of 38 breaths per minute. His obesity predisposes him to rapid desaturation due to a severely reduced functional residual capacity and increased metabolic demand. We positioned him in a ramped configuration, elevating his head and shoulders to align the ear with the sternal notch, optimizing airway alignment. Pre-oxygenation with high-flow nasal cannula at 60 liters per minute and 100% FiO2 for 5 minutes raised his SpO2 to 96%, extending his safe apnea time. Intubation using video laryngoscopy achieved first-pass success, with his oxygen saturation remaining above 90% throughout. This case underscores the importance of tailored positioning and aggressive pre-oxygenation in obese patients, transforming a high-risk scenario into a controlled intervention. The takeaway is clear: proactive measures can significantly reduce the risk of hypoxia in this challenging population. Now let's discuss another challenging patient population: the pregnant patient. Pregnancy significantly alters respiratory and airway physiology, posing unique challenges during airway management. Hormonal changes, particularly increased progesterone, relax smooth muscles, including the lower esophageal sphincter, which heightens the risk of aspiration, especially critical in the setting of emergency intubation. The growing uterus displaces the diaphragm upward, reducing functional residual capacity by 20 to 30%, which, when combined with a 20 to 50% increase in oxygen consumption due to fetal and placental demands, leads to rapid desaturation during apnea. For example, a pregnant patient may desaturate to less than 90% within 2 to 3 minutes of apnea compared to 5 to 8 minutes in non-pregnant adults. Additionally, increased estrogen levels cause capillary engorgement and edema in the upper airway, making it more friable and potentially difficult to intubate, with a higher incidence of failed intubation, for example 1 to 250 versus 1 to 2,000 in non-pregnant patients. These physiologic changes necessitate careful planning and adaptation of airway management techniques to ensure both maternal and fetal safety. Effective airway management in pregnancy requires a multifaceted approach to address the unique physiologic challenges. Pre-oxygenation is critical. Using a non-rebreather mask at 15 liters per minute for at least 3 to 5 minutes can achieve an SpO2 greater than 98%, extending the safe apnea time. In cases of severe hypoxemia, high-flow nasal cannula or non-invasive positive pressure ventilation may be considered to further optimize oxygenation. Positioning the patient in a left lateral tilt, 15 to 30 degrees, with a wedge under the right hip is essential to prevent aortocaval compression by the gravid uterus, which can reduce venous return and cardiac output by up to 30%, leading to hypotension and fetal distress. Due to potential airway edema, smaller endotracheal tubes, 6 to 7 millimeters, are recommended, and video laryngoscopy is preferred over direct laryngoscopy to improve glottic visualization and reduce the risk of multiple attempts. RSI with etomidate and succinylcholine, or rocuronium, minimizes the unprotected airway period, and cricoid pressure of 10 to 30 newtons, or 1 to 3 kilograms, may be applied to reduce the risk of aspiration, although its efficacy remains debated. Due to the longer duration of action rocuronium, if used, the ventilator should be set to approximate the pre-intubation respiratory drive. The goal is to secure the airway swiftly while maintaining oxygenation and hemodynamic stability, ensuring the safety of both mother and fetus during this high-risk intervention. Let's discuss another case example. Consider a 32-year-old female at 36 weeks gestation with severe preeclampsia, presenting with altered mental status, SpO2 of 92% on room air, and signs of pulmonary edema, necessitating emergent intubation for airway protection. The challenges are multifold. Her decreased functional residual capacity and increased oxygen consumption predispose her to rapid desaturation, while the relaxed lower esophageal sphincter heightens aspiration risk. Additionally, airway edema from preeclampsia increases the likelihood of a difficult intubation. We initiated pre-oxygenation with a non-rebreather mask at 15 liters per minute for 5 minutes, achieving an SpO2 of 98% to maximize her oxygen reserves. She was positioned in a left lateral tilt with a wedge under her right hip to maintain hemodynamic stability. Rapid sequence intubation was performed using etomidate and succinylcholine to minimize the unprotected airway period, and a 6.5 mm endotracheal tube was selected to accommodate potential airway swelling. Video laryngoscopy facilitated first-pass success, and her SpO2 remained above 95% throughout the procedure. Post-intubation, a nasogastric tube was placed to decompress the stomach, further reducing aspiration risk. This case illustrates the effectiveness of tailored airway strategies in pregnancy, emphasizing pre-oxygenation, optimal positioning, and RSI to mitigate risks and ensure the safety of both mother and fetus. The takeaway is that with careful planning and adaptation to physiologic changes, we can navigate these high-stakes scenarios successfully. Transitioning to the next topic, large pericardial effusion or tamponade, we shift from the meticulous planning required to address the pregnancy-specific physiologic changes of the obstetric airway to equally precise strategies needed to manage the critical hemodynamic instability caused by pericardial compression in cardiac tamponade. Large pericardial effusion or cardiac tamponade occurs when fluid accumulates in the pericardial sac, elevating intrapericardial pressure and compromising cardiac function. Common causes include malignancy, infectious pericarditis, trauma, or uremia, with tamponade representing the severe end of the spectrum where external compression significantly impairs diastolic filling. Physiologically, this restriction reduces stroke volume, triggering compensatory mechanisms such as tachycardia and systemic vasoconstriction to preserve cardiac output and blood pressure. However, in tamponade, these mechanisms are often inadequate, leading to a low cardiac output state with mean arterial pressures as low as 50 to 60 millimeters of mercury. Positive pressure ventilation during intubation further complicates this by increasing intrathoracic pressure, reducing venous return, and exacerbating hypotension, a phenomenon that can precipitate cardiovascular collapse within minutes. Recognizing these dynamics is essential for managing the airway in this precarious condition. Managing airway intervention in the presence of large pericardial effusion or tamponade requires careful hemodynamic and ventilatory strategies. Pre-intubation, a fluid bolus, 500 to 1,000 milliliters of crystalloid fluids, can augment preload in patients with some cardiac reserve, while inotropes like dobutamine enhance contractility without significantly increasing afterload, supporting cardiac output in low-output states. If tamponade is confirmed via echocardiography, for example, RV collapse, IVC plethora, urgent pericardiocentesis should be performed prior to intubation to relieve pericardial pressure and restore ventricular filling. This can increase mean arterial pressure by 20 to 30 millimeters of mercury. During intubation, ventilator settings should minimize intrathoracic pressure, low tidal volumes, 6 milliliters per kilogram, and minimal PEEP, 0 to 5 centimeters of water, reduce the impedance to venous return. Induction agents like etomidate are preferred for their hemodynamic stability. The goal is to maintain cardiac output and prevent the catastrophic hypotension that can occur with positive pressure ventilation, ensuring a stable transition to mechanical ventilation. Having explored the hemodynamic challenges of large pericardial effusion and tamponade, let's examine a case example to illustrate how these principles guide airway management in a real-world clinical scenario. A 60-year-old female with metastatic breast cancer presents with a blood pressure of 85/50, heart rate of 130 beats per minute, and an echocardiogram revealing a large pericardial effusion with RV diastolic collapse, diagnostic of cardiac tamponade. The risk of cardiovascular collapse during intubation is high due to compromised cardiac output and the potential for positive pressure ventilation to further reduce venous return. We administered a 500 milliliter crystalloid bolus and started dobutamine at 5 micrograms per kilogram per minute to bolster cardiac output, raising blood pressure to 90/55. Urgent pericardiocentesis, guided by ultrasound, drained 400 milliliters of serosanguinous fluid, improving blood pressure to 100/60 and relieving RV compression. Intubation was performed using etomidate and low tidal volume ventilation with minimal PEEP, maintaining hemodynamic stability throughout. This case highlights the critical role of pre-intubation pericardiocentesis and hemodynamic optimization in tamponade, preventing the lethal consequences of positive pressure ventilation. The takeaway is that addressing the underlying cardiac compression is paramount before airway intervention. Moving to our next topic, high aspiration risk, we transition from the hemodynamic complexities of managing large pericardial effusion and tamponade to the critical airway management challenge of mitigating aspiration risk, where understanding the pathophysiology and implementing preventive strategies are vital to patient outcomes. High aspiration risk is a critical concern in airway management, defined by conditions that predispose to gastric content inhalation, such as altered mental status, for example, from stroke or intoxication, vomiting, gastrointestinal obstruction, or recent food intake. Physiologically, aspiration of acidic gastric contents triggers chemical pneumonitis, characterized by alveolar edema and hemorrhage, leading to hypoxemia within hours. Secondary bacterial infection may cause aspiration pneumonia, while severe cases can progress to ARDS, with PF ratios less than 200. The inflammatory cascade can precipitate systemic inflammatory response or sepsis, significantly increasing mortality, up to 30% in ICU patients. During intubation, the risk of aspiration peaks due to loss of airway reflexes, particularly if the procedure is prolonged or multiple attempts are required. Understanding this pathophysiology is essential for implementing strategies to minimize aspiration events. Managing high aspiration risk focuses on minimizing the window of airway vulnerability. Rapid sequence intubation is the cornerstone, using a rapid onset paralytic like succinylcholine or rocuronium to achieve immediate muscle relaxation, reducing the time from induction to tube placement to less than 60 seconds. Induction with etomidate ensures hemodynamic stability. Positioning the patient head up at 30 to 45 degrees leverages gravity to reduce regurgitation risk, particularly in patients with full stomachs. Pre-intubation preparation includes ensuring a functioning suction device and, in select cases, gastric decompression via nasogastric tube to reduce gastric volume, though this must be balanced against procedural delay. Cricoid pressure is controversial due to limited evidence and potential airway obstruction, and its use should be operator-dependent. The goal is to secure the airway swiftly, minimizing the unprotected period and preventing aspiration, which can double ICU length of stay and mortality risk. Having outlined the pathophysiology and risks for aspiration, let's now turn to a case example to demonstrate how these principles are applied in a clinical scenario to effectively manage and minimize aspiration during airway intervention. A 50-year-old male presents with alcohol intoxication, a Glasgow Coma Scale of 8, oxygen saturation of 92%, and a history of recent meal consumption, placing him at high risk for aspiration due to impaired airway reflexes and gastric contents. The challenge is to secure his airway without allowing regurgitation during intubation. We positioned him head up at 30 degrees to reduce the likelihood of passive regurgitation. Rapid sequence intubation was performed using etomidate and succinylcholine, achieving intubation within 45 seconds on the first attempt, with a functioning suction device readily available. Post-intubation chest X-ray showed no evidence of aspiration, and oxygen saturation improved to 98%. This case highlights the efficacy of rapid sequence intubation and head-up positioning in minimizing aspiration risk, ensuring a rapid and secure airway intervention. The takeaway is that meticulous preparation and swift execution are critical to preventing aspiration-related complications in high-risk patients. In conclusion, we've covered 8 physiologically challenging airway scenarios: hypoxemia, hypotension, severe metabolic acidosis, right ventricular failure, pericardial effusion and tamponade, obesity, pregnancy, and increased risk of aspiration. Each poses unique risks during intubation that require specific strategies to mitigate complications. For hypoxemia, pre-oxygenation and apneic oxygenation prolong safe apnea time. Hypotension demands preemptive hemodynamic stabilization with fluids and vasopressors. In severe metabolic acidosis, preserving spontaneous respiration and using patient-triggered ventilation supports compensation. RV failure necessitates careful ventilatory and hemodynamic management to prevent worsening strain. Pericardial effusion or tamponade may require pre-intubation pericardiocentesis to avert collapse. Obesity calls for ramped positioning and robust pre-oxygenation to counter rapid desaturation. In pregnancy, adapting to physiologic changes with left lateral tilt, smaller endotracheal tubes, and rapid sequence intubation ensures safety for both mother and fetus. For patients with high risk of aspiration, rapid sequence intubation and head-up positioning can help minimize aspiration risk. Mastering these approaches enhances your ability to manage complex airways effectively. As we bring this presentation to a close, let us reflect on the profound responsibility we carry in airway management. The challenges we've explored today, hypoxemia, hypotension, severe metabolic acidosis, and more, are not merely clinical hurdles. They are defining moments where lives hang in the balance. Your knowledge and skill transform chaos into calm, uncertainty into hope. In every intubation, every intervention, you stand as guardians of the breath, the keepers of possibility, entrusted with the sacred duty to preserve life when it matters most. Carry this wisdom with you, wield it with precision and compassion, and let it inspire you to be the steady hand and steadfast heart your patients need. Thanks for listening.